Hello everyone, welcome back to the channel Pharmacology Simplified. In this video, we are going to discuss about hypertension, how hypertension develops in people, and what are the drugs, what are the pharmacological agents that are used for management of hypertension. So let's first have a brief overview of what hypertension is. So if we ask ourselves that what is hypertension? So a state where there is sustained elevated blood pressure of values more than 140 by 90 mmHg can be referred to as hypertensive state. And why this hypertension is dangerous? It is dangerous because this high blood pressure in the blood vessels can lead to bursting up of the blood vessels. And the blood vessels in the brain, eye, kidney, and all the blood vessels with thin walls, they can rupture and can lead to severe conditions that may even prove fatal in patients. So now we see what are the organs that are regulating blood pressure in our body. So first we have the heart that generates the blood pressure. Then we have kidneys. Then we have liver, lungs, and the brain. I'm poor at drawing, so I have written brain. So heart regulates blood pressure by the rate and force of contraction that regulates the cardiac output. Kidneys, they also have adrenal gland on their surface. So the adrenal gland releases aldosterone, and the kidneys, they regulate blood volume, they regulate ion balances, and they also regulate or activate the RAS mechanism. Liver produces angiotensinogen, lungs produce angiotensin converting enzyme ACE, and the brain releases noradrenaline. Along with this, blood vessels also play a very important role in regulating the blood pressure. Blood vessels are lined with a single layer of cells called endothelium, and they have smooth muscle cell referred to as VSMC, vascular smooth muscle cells. So the endothelium can change the caliber of the blood vessel by contracting or relaxing the smooth muscles. So when there is fall in blood pressure, there is activation of baroreceptor reflexes, and this fall in blood pressure also leads to underperfusion of the kidney, that leads to activation of RAS, renin, angiotensin, and aldosterone system. And this baroreceptor reflex is mediated with release of noradrenaline by increased sympathetic activity, and the RAS is initiated by renin. So let's see first the mechanism how RAS regulates our blood pressure. So we are having kidney, we are having our liver, and lungs will be playing a role in this. So we see whenever there is decreased blood volume, right, this will lead to renal ischemia or underperfusion of the kidney. So in response to this low blood volume received by kidneys release renin. Now liver already release angiotensinogen, it is inactive, and this angiotensinogen is acted upon by renin, and it is converted into angiotensin 1, or we abbreviate it as AT1. Now this angiotensin 1 is the substrate for angiotensin converting enzyme that is released by lungs. Now this angiotensin 1 is converted into angiotensin 2 by ACE. Now this angiotensin itself is a very potent vasoconstrictor. That means it can cause constriction in the blood vessels, and this angiotensin 2 has several physiological effects. It shows its effects on the adrenal gland. Adrenal gland, we had seen that it is present on the top of the kidney, and adrenal cortex, it releases aldosterone, and aldosterone has the action of sodium retention, and wherever sodium goes, water follows. Angiotensin 2 also shows its action on kidney and intestine, where it increases sodium and water reabsorption. In the CNS, This angiotensinogen leads to a release of ADH, antidiuretic hormone, that contributes towards increasing blood volume. ADH also has some action on kidney for producing concentrated urine. In the peripheral nervous system, there is increased sympathetic activity, that means increased release of noradrenaline, that will bring about increase in the total peripheral resistance. This ADH also increases total peripheral resistance, and CNS also increases sympathetic activity. So several factors are pouring in for increasing the blood volume. On the vascular smooth muscle cells, there is contraction, and this leads to increased total peripheral resistance. Angiotensin 2 also acts on heart, and it increases the contraction, the force of contraction, leading to increased cardiac output. And all these factors contribute towards increase in blood pressure. This is physiological part, but if these conditions go out of control or they go beyond a certain point, then this leads to hypertension. So now we will see what are the potential targets that we can modify for preventing hypertension or for preventing uh, the symptoms or the morbidities that are associated with hypertension. So we can reduce blood volume, cardiac output can be reduced, RAS activation can be reduced, vascular smooth muscle cell should be relaxed, there should be increased vasodilation, and reduce adrenaline action. So there are potential targets. We can target renin, ACE, aldosterone we can target. Along with this, we can target ADH, antidiuretic hormone. We can target the sympathetic activity, the smooth muscle contraction, and the contraction of the heart. So this will be regulating our blood pressure, right? So let's move ahead now. Now we will see the pharmacology of antihypertensives. Antihypertensive drugs are those that help in reducing the blood pressure in a patient. So we'll be seeing one by one every drug. So whenever there is renal ischemia, we have seen the renin-angiotensin-aldosterone system. There will be release of renin that will convert angiotensinogen into angiotensin 1. This angiotensin 1 will be acted upon by ACE, and this ACE will convert angiotensin 1 into angiotensin 2. And this angiotensin 2 will show its effect by releasing aldosterone and some other actions in the physiology, ultimately contributing towards the increase in the blood pressure. So first we will see renin. So we can give renin inhibitors. The example is aliskiren. What it does, it inhibits conversion of angiotensinogen into angiotensin 1 by inhibiting the actions of renin. So it is directly all this RAS pathways inhibited. And next we have ACE inhibitors. So ACE inhibitors, we can remember them as prils. These drugs end in prils, and they inhibit conversion of angiotensin 1 into angiotensin 2. Example is captopril, enalapril, ramipril, perindopril. So they have some adverse effect associated with them. They develop dry cough in patients. They produce rashes. Hypotension is one of the adverse effects. They also develop fever, and hyperkalemia is also one of the symptoms associated with angiotensin converting enzyme inhibitors. Dry cough, maybe it may become troublesome in patients having asthma. They can also lead to development of angioedema, and yes, these drugs are not to be given during pregnancy. Next, we have angiotensin 2 receptor blocker. See, when angiotensin 2 is formed, it binds to its receptor and then it shows its action. So, angiotensin receptor blockers, they end with sartans, candesartan, telmisartan, irbesartan. So, what they do, they block angiotensin 2 receptors so that angiotensin 2, even which is formed, cannot show its action because it is not able to bind to its receptors. And the adverse effects are similar to ACE inhibitors, but this dry cough is not seen, and this case of angioedema, they have lesser incidence in comparison to the ACE inhibitors. And yes, these angiotensin receptor blockers, they are also not to be given during pregnancy. So we have seen three potential targets: renin inhibitors, ACE inhibitors, and angiotensin receptor blockers. And these Angiotensin receptor blockers, they are better tolerated than angiotensin converting enzyme inhibitors, ACE inhibitors. And if patient has developed severe coughing, then we also recommend angiotensin receptor blockers. Next target we have by modulating the alpha receptors, alpha adrenergic receptors. There are two types of alpha receptors, alpha 1 and alpha 2, and they are acted upon by adrenergic receptor. The alpha 1 receptor, it is responsible for causing vasoconstriction. Let's see them one by one. So we would be using alpha 1 inhibitors and alpha 2 agonists in hypertension. Alpha 2 activation leads to inhibition of noradrenaline release. So whenever alpha 2 is activated, the release of noradrenaline will be inhibited. Alpha 1 inhibitors, they end up in zosine, prazosin, doxazosin, terazosin. They are located on arterial smooth muscles, and noradrenaline, and they inhibit the actions of noradrenaline, adrenaline, uh, and they provide vasorelaxation. So this leads to reduction in total peripheral resistance, and they have less effects on cardiac output, glomerular filtration rate, and renal blood flow. And yes, the adverse effects that are associated with alpha 1 blockers are sodium and water retention. Along with it, they develop postural hypotension, like whenever there is change in the posture, so there is no activation of the baroreceptor reflex. They develop reflex tachycardia, and a first dose syncope is also seen in patients. And yes, alpha 1 antagonists, they are often given with beta blockers for reducing the reflex tachycardia associated with alpha 1 actions. And when we talk about alpha 2 receptors, so they are the presynaptic receptors, and their stimulation leads to the inhibition of adrenaline or noradrenaline release. So these drugs, they reduce sympathetic outflow, and they have no effects on glomerular filtration rate and renal blood flow. So they can be used in patients that have hypertension along with the renal insufficiency. And the adverse effects associated with them are sodium and water retention, and they are often used with diuretics to reduce the blood volume or the total plasma content in the body. They do lead to development of rebound hypertension if their dose is abruptly stopped. So the dose has to be reduced gradually, and they often cause sedation in patients. And this was example of clonidine. One more alpha 2 agonist is there, methyl dopa. It reduces total peripheral resistance. Methyl dopa is also an alpha 2 agonist. It reduces total peripheral resistance, hence leading to reduction in blood pressure, and it has no effect on cardiac output. And it is preferred in patients with renal insufficiency, and it is also preferred in patients having pregnancy induced hypertension. Adverse effects are sedation and drowsiness. They are associated with methyl dope. Next is one of the very important class of drugs, beta blockers. So they are the inhibitors of beta receptors. Beta receptors, as we know, are of three types: beta 1, beta 2, and beta 3. But here we are focusing on beta 1 because they are the cardioselective. They have their location on cardiomyocytes and automatic fibers. They are also present in the JG cells in the kidney that are responsible for production of renin. So when we see the mechanism of action of beta blockers, they prevent adrenaline noradrenaline to stimulate their own receptors, the beta 1 receptors. And these beta 1 receptors that I'm talking about are the receptors present on the automatic fibers that generate the impulses. So they slow down the heart rate. And since they are slowing down the heart rate, they are also reducing the cardiac output. So there will be reduced blood pressure. They also inhibit renin release, so they will also contribute towards the inhibition of RAS activation. And you can remember them by olols. They end in olols: propranolol, metoprolol, atenolol, esmolol. Every drug, right? And yes, they have few adverse effects associated with them. We can say they have hypotension. People develop hypotension. They slow down heart rate, so people can develop bradycardia, dizziness, insomnia. Sexual dysfunction is one of the very huge reason that leads to non-compliance of the drug, and males are more affected with this. They also alter lipid profile by inhibiting HDL and by increasing triglyceride levels. And yes, they do reduce the exercise capacity of a patient. They lead to development of rebound hypertension. So their dose is to be reduced gradually over a period of time, so that there is no development of rebound hypertension in the patients. And yes, these drugs are to be used very cautiously in cases of asthma and in patients with heart failure, because the non-selective beta blockers will also inhibit beta 2, and beta 2 is responsible for bronchodilation. Next approach is reducing total peripheral resistance and cardiac output. So for this, we can target the calcium channels. In our cardiovascular system, we have primarily two types of calcium channels: the one that are present on the heart and the other that are present on the blood vessels. Blood vessels hold the L-type calcium channels, and the heart holds both L-type and T-type calcium channels. So in the blood vessels, the calcium influx through L-type calcium channels leads to vasoconstriction, while this influx of calcium through L and T type causes both causes the increased force of contraction of the heart. Calcium channel blockers, they are categorized into three types. There are three families: diphenyl alkylamines, benzothiazepines, and third are dihydropyridines. If we see them, then the dihydropyridines are more vasoselective, while the diphenyl alkylamines, they act on heart and blood vessels both, and benzothiazepines, they are less strong negative inotropic effect. The calcium channel blockers, they have negative inotropic, that means they reduce the force of contraction in the heart. So they are used, diphenyl alkylamines, they are used in migraine, they are used in angina pectoris and supraventricular tachycardia. The adverse effects associated with them are constipation, vertigo, headache, fatigue, hypotension. Hypotension is mostly associated with almost every category of the drug used for managing hypertension. And calcium channel blockers are not to be given in patients with congestive heart failure, because they reduce the force of contraction, right? And in patients with congestive heart failure, their heart is not able to pump sufficient amount of blood. The next category of drug is also very important: diuretics. Diuretics, what they do, basically they reduce the blood volume, so hence there will be reduced total peripheral resistance, and we will find reduction in blood pressure. So this is a very basic structure of a nephron. You can see the different parts of nephron. You have Bowman's capsule, you have PCT, you have descending loop of Henle, you have ascending loop of Henle, then we have the DCT, and ultimately the collecting tubule. So the blood comes through the afferent and through the afferent arteriole, and it is filtered, and then it passes through the whole length of the nephron before eliminated from the body as urine. So increase in urine output will lead to reduced blood volume, reduced total peripheral resistance, and reduced blood pressure. There are three major classes of the drugs that are used for reducing blood volume in hypertension: the loop diuretics, the thiazide diuretics, and potassium sparing diuretics. They have their different sites of action. We'll be discussing them right now. So first site, the loop diuretics, they show their actions at the ascending loop of Henle, where they inhibit sodium 2 chloride potassium cotransporter. What it does, it pumps sodium chloride and potassium from the glomerular filtrate back to the blood. So when this is inhibited, there is more excretion of sodium chloride and potassium in the urine. Next, we have our thiazide diuretics. They act at a different site, and what they do, they inhibit one transporter that reabsorbs sodium and chloride. So when they inhibit both this sodium and chloride, then what will happen? There will be more release or more urination of sodium and chloride. And in the last, we have potassium sparing diuretics. It has its site of action in the collecting tubule. What it does, it inhibits this sodium and potassium exchanger, where potassium is exchanged with sodium. So what is happening here? This potassium sparing diuretic, it is inhibiting this pump, so there is no excretion of there is no reabsorption of sodium and there is no excretion of potassium. Hence potassium is spared, and for this reason they are called as potassium sparing diuretics. But it is not like that they do not have the side effects associated. They have several side effects associated with them. Ultimately, all these are contributing towards more excretion of sodium, potassium, and water through the urine. That leads to reduction in blood volume, and this reduction in blood volume leads in relief in hypertension. So, the loop diuretics and thiazide diuretics, they have the adverse effects is hypokalemia. Hyponatremia is low content of sodium in the body. With this, they can develop nausea, they can develop vomiting in patients. Along with this, they develop impotence. They do produce hearing loss due to depletion of potassium, and in some cases, they also precipitate gout by hyperuricemia. They also produce hyperglycemia, hyperlipidemia, and sometimes they also lead to deficiency of magnesium in the body. And thiazide diuretics, they also reduce GFR, and hence they are to be used cautiously in patients with renal insufficiency. While the potassium sparing diuretics, they are free from development of hypokalemia. Instead, they often develop hyperkalemia in patients. They lead to development of drowsiness and confusion in patients administering them. Along with this, they lead to development of gynecomastia. They also develop erectile dysfunction and loss of libido is seen in many of the patients. Yes, it also develops menstrual irregularities in females. The last class of drug is endothelin receptor antagonists. We had seen in the very beginning that the blood vessels, they have a lining of endothelial cells. What are endothelial cells? They are single layer of cells that release nitric oxide that is responsible for the vasodilation, and these endothelial cells can also lead to the contraction of the blood vessels. That means they can regulate the caliber, the lumen, the diameter of the blood vessels by relaxing or contracting the vascular smooth muscle cells. So these endothelial cells, they have ET or endothelin receptors, and these endothelin receptors, what they do, when endothelins are very potent vasoconstrictors. So whenever these endothelins, they bind to these ET receptors, they cause severe vasoconstriction, leading to increase total peripheral resistance, and subsequent increase in the blood pressure. So the mechanism of action is inhibition of endothelin receptors, and they prevent binding of endothelin to the receptors, as a result of which there is no vasoconstriction and they induce vasodilation. Their adverse effects are they lead to birth defects in unborn babies. They reduce sperm count in some patients. Along with this, they reduce hemoglobin values in patients, and they are often accompanied with uh, hypersensitivity reaction. They also lead to development of diarrhea and gastroesophageal reflux disease in some patients. Bosentan is one of the examples of endothelin receptor antagonist. It has more affinity towards ET1 receptor rather than ET2 receptor. So thank you very much for watching this video. If you have been able to identify or understand anything out of this video, please subscribe to the channel, share the video as much as possible. Happy learning to all of us. Thank you very much.